We are here to take on the last session of the day, which talks about the non-communicable diseases and what Dr. Reddy calls the silent pandemic. So, building resilience against NCDs, the silent pandemic is the session that we have for this evening. And of course, followed by that is the networking dinner. At 6:25, across the road where we have been having our lunch, is where people can break their fast before they can have dinner. So, looking forward to having you all there for dinner too. Please join me in welcoming the panelist. Moderating this session is Dr. Krishna Reddy. Joining us on the panel is Dr. Prabhakaran, a cardiologist and epidemiologist by training, an internationally renowned researcher, and currently the executive director for Center for Chronic Disease Control. Dr. Meenakshi Sharma, Scientist G, she's online. Scientist G, Indian Council for Medical Research and Government of India, and we will have her presence virtually. Dr. Ratna Devi, who will bring in her insights, the CEO and founder of Dakshakarma Health and Education. And we've heard her before this morning. Improving health outcomes is something that she will talk about. Dr. Parag Bharmare, Technical Lead Women's Cancer, Japaico. Focus on immunization, maternal health, child health, and women's cancer initiatives. Thank you, Dr. Parag. And Mr. Ram Khandelwal, founder of Heart Health India Foundation, HHIF, committed to raising public awareness about heart disease and how to manage health. Thank you, Mr. Khandelwal.
Invite Himani also.
Yeah.
Representing Satis.
Okay. We also have our Global Program Director, Himani Sethi from Access Health International, and she will represent and present her work on what they have done over the last 5 years in UP with the Sachis. I now hand it over to Dr. Reddy to take the session forward. And I know it's going to be one great session that we will have. Thank you.
Thanks for all of you who are present here at this part of the day. As we have seen, we have been taking through the different crises, how the health systems have to adapt and become resilient. The first one was the climate change. Then there was focus on building robust surveillance systems for the infectious diseases. And the last one was for the climate change. These are mostly talked about health crisis and the health threats in the global health ecosystem. But what most of the policymakers and most of the global health ecosystem, most of the international development assistance, they forget about the pandemic, which kills more people than any other pandemic. All of us know that NCDs account for almost 2/3 of the deaths, including in the LMICs. And more than that, 2/3 of these deaths are premature and preventable. That means the millions of the deaths dying before 60 years of age or 65 years of age, they're highly preventable and premature. Though there is a commitment as a part of the Sustainable Development Goals to reduce these premature deaths by 1/3 by 2030, only 17 countries out of the 190 countries are on track. And this is not after the COVID pandemic. This is before the COVID pandemic. That means none of the countries are on track to, because it's lack of the needed attention in enforcing some of the commitments made as a part of the SDG goals. There is a policy awareness because every country has committed for that. There is a policy attention because most of the countries have put them into their national health plans. And many countries have also announced their national action plans depending upon their priorities and their capacities and their financial resources. Why we thought we should bring NCD as a part of this conclave? One, to bring it to the upfront as an ongoing health crisis, not as something which is routine. And more importantly, this year is the golden opportunity because after 5 years, it is featuring in the UN General Assembly agenda, the NCD control. So that is another reason why we thought this is appropriate for this event in terms of building resilience. And we have an excellent panel, again reflecting the morning session in terms of listening to the patient's voice, listening to the people's voice. So this panel also will start with the patient voice, Ram. He himself is a patient, had an MI at the age of 33 years. And the experience that he has gone through in the current system, and also the policy documents that come out from the country, which are maybe far removed from what actually the patients want in terms of the health needs arising out of the non-communicable diseases. So I start with Ram as a patient, I mean, with experienced thing. And also you have been going through the patient advocacy and the policy advocacy. You have been reviewing some of the national policies and the national action plans from an advocacy point of view. When you when you look at the national action plan announced the last year as a revised national action plan of the India, from a patient perspective and as a representative of one of the NCD group of patients, what is your perspectives on that?
I'd like to start my discussion by asking a question to everyone here. How many of you have a heart patient in family? Either, yes. Do you see that there are challenges which patients face which are outside of hospital premises? What kind of challenges? Anyone would like to tell what challenge patients face? Okay, that's classically what happens. We don't come out. Yes. I totally agree with you on both the points. In fact, when I had a heart attack, I was 33, like we were talking about earlier. And at that time, it never bothered to me that before I turn 40, I actually need to stay focused on what kind of checkups needs to be done. And when I was working in a corporate setup, even there we used to have allowances, we used to have packages, insurance coverages where you could get yourself tested annually. But many like me, actually, and I talk to a lot of people in our community, they don't get themselves tested, even if there is a free health checkup which is there, because it's not on their priorities. So why this is happening? We say that 8 out of 10 cardiac events are preventable, but we think it is not happening to me. And that is one of the major reasons in terms of not me syndrome. So, most of us who are actually at the risk of heart disease, these are typical lifestyle risk factors: lack of sleep, exercise, nutrition, uh, obesity, stress. Yes, one of the major factors. And then on top of it, we are not getting ourselves tested. So it is all adding to our risk factors and increasing our risk. Plus, we live in cities like Delhi or other polluted cities, which also adds a strain on quality of life and environmental factors, which increases our risk. Despite living with all these factors, we are not asking ourselves that can this happen to me? And specifically from a heart disease perspective, the reason is these diseases are asymptomatic. Just one day before, when I had a heart attack, I was going out with my family and spending a normal Sunday like anyone else. Bam, 9:30 a.m. in the morning, I'm in hospital. So what happens? There is that we don't think that heart disease can happen to me. Heart disease can happen to young. Heart disease can happen to poor and rich equally. Heart disease can happen with men and with women. Most of us believe that it's postmenopausal, that women will go through heart attacks. But nowadays, in our community only, we see women who are below the age of 40 actually getting attacks. They are not coming out and telling you. That is the issue. Many of these voices are not actually coming out, and they are not telling people. They are politicians who have gone through a silent heart attack, or maybe somebody at your workplace who has gone through a heart attack, not come back and told you. Because the moment they tell you, you will not treat them the same way you were treating them earlier. Either you will be extra cautious working with them, or you will avoid working with them. These are some of the practical challenges which patients face, and which is leading to reduction in awareness. In terms of raising the voices, we are seeing less people talking about it, about the real life incidences. So that's one. Second part, which is equally important, is post care. So we are getting a treatment for a disease, but we are not being able to help the patients. These are two different perspectives. Patients has a life cycle, which was even before, when they were not aware, and even after they come out of hospital, when they are on a medication or a treatment, they go through a lot of mental health issues. They go through a lot of educational issues. So living with a condition in itself requires a certain level of sensitization. In our country, we have a lot of challenges when it comes to patient education. Somebody who learns about cancer or who learns about heart disease, they learn from their own experiences and then trying to know more how to live a life with that disease. So that patient education aspect, specifically how to live with a heart condition, for example, in case of CVDs, is totally missing. Because in the conventional setting, if I go and ask who can help me understand more about my condition, there's no one. You can ask doctors, but in a setting like India, how much time you will be able to spend with your cardiologist? So these communities that we are trying to build today, where we have about 4,000, 5,000 people coming together, where we are trying to curate their experience by bringing in doctors, cardiologists, we are helping to educate patients about how to live better with their own condition, what kind of medications they are taking, why they should take it, or what kind of symptoms they should not ignore, what kind of checkups they should not ignore. Plus, people are also talking about things which we would have conventionally not thought of as subjects to be discussed within the patient community. For example, how are you managing your lifestyle? How are you managing your finances? Even, for example, if we go to global forums, people will talk about reproductive health, sexual health, and heart disease. If you talk about it in Indian context, you will not find anyone openly talking about it. That's the power of patient communities that we are seeing today. And I think it is opening up avenues for us to learn that what patients want, what are the requirements which patients look, which is beyond medicine or beyond clinical treatment. And I think as a life cycle approach, we should look at patients as a holistic well-being. And the national action plans, when they look at treatment of a patient, they should look at the life cycle approach and bring together this perspective that patients is beyond disease. So we just don't have to treat the disease, we have to help patients. And if we have to help patients, the policies needs to be designed around it. Just for example, cardiac rehab in our country right now, though it's a class 1A recommendation, but how many heart patients actually go through a cardiac rehab? We are working with 5,000 people. Hardly anybody knew about it before we started talking about it. And then people came and asked us that, okay, where can I get a cardiac rehab done? So they have got a angioplasty done, they have got a CABG done, and they don't even know that they should be taking up a cardiac rehab. And so these are the typical challenges which patients face, and I think this needs to be mainstreamed in the policy action plans so that we can have more responsive plans for patient needs.
Thanks, Ram. I think that brings me to actually question Dr. Prabhakaran, who has been championing public health and research, especially centered around the chronic diseases in general, and more so the non-communicable diseases. Of course, being a cardiologist with special love for cardiovascular diseases. Given this public health background, as well as a health researcher background and a clinician background, and also actually working with the Ministry of Health and the ICMR and the WHO, the revised National Action Plan on the non-communicable diseases, I was going through that and I had some concerns in terms of how it is designed. But I do understand from a public health perspective, priority settings and those things will come into the picture. But I just wanted your perspectives in terms of what are the challenges in implementing the existing plan, and also what you think are some of the critical gaps in the existing plan.
Thank you, Dr. Reddy, for inviting me here. As you know, Otto von Bismarck, who was the Chancellor of Germany at the end of 19th century, said, you shouldn't do or discuss two things in public. One is how to make sausages, and second is how to make policy. Because if you look at the process behind this revised plan, it's nearly taken 15 years, because every clinician, every specialist wanted his or her area to be given priority and addressed. So they were not even, it was like seven blind men describing an elephant. So seven different people coming together and saying, we should do this, we should do that. I am kind of happy that it has actually seen the light of the day with, there may be gaps and challenges, but it has a lot of good elements. And what are the good elements in that? Number one is the primacy of primary care has been, because you don't require specialists to manage 80% of the non-communicable diseases. Second, it emphasizes prevention, which is an important, and it actually looks at 5 areas of prevention. And those are easily implementable, except that the government itself is not taking any action on the fifth one, which is air pollution. The third thing is it talks about health system redesign using technology, but it's an intent and we need to follow it up with action. And it looks at these usual things of by 2030 we have to reduce it by 30%. It talks about the SDG goal 3.4 and looks at governance mechanism and all that. But what is the missing piece? There are several missing pieces. One is a community engagement. There has been no community voice over there in terms of the framing that policy. Number two is private sector engagement. I mean, they consulted private sector physicians and others, but it talks only about the government system, starting from health and wellness clinic, health and wellness center to the tertiary care center. It's all government centered. private care gives almost 70% to 80% of the care in this country. And how do you engage with them is not mentioned except in the domain of Ayushman Bharat, the PMJ program. Other than that, there is no mention. The third is simplification of treatment. It talks about standard treatment protocols, but we need to look at adherence, for example, patient adherence is virtually for many of the chronic diseases. Take hypertension, which is the simplest example. I'm not looking even at complex diseases. Hypertension, as they say, it's a disease of three paradoxes. Easy to diagnose, but the awareness is extremely poor. In fact, in the best of situation in urban areas in India, it's around 50%. In the worst case scenario, it's around 20-30%. Easy to manage, easy to treat, but treatment rates are poor. And treatment to targets is extremely poor. It's estimated to be around 8% in urban area and 12% in rural area. And the power of managing hypertension, just as a simple example, if we were able to get 50% of the patients to targets across the world, we would save 76 million lives by 20 years, over a 20-year period, between 25-year period, between 2023 to 2050. You're likely to save 76 million lives and prevent many strokes. So given that, the huge problem is the idea of implementation. How do you implement these gaps, and what are the challenges in implementation? I think the big challenges in implementation are team based approaches are not there. They very cursorily mention it there, but it is really not there, because when you actually go to the field and see, where we are working in Tripura in terms of redesigning the health system over there to cater to NCD, there is no communication between a community health worker, a nurse, a physician, and then the administrators, because everything is top down hierarchical. So how do you create the team based approaches? And second is, it's not patient centered. The third area is, it's not taking into account some of the simple innovations, like for example, fixed dose combinations have been shown to increase adherence by 33%. We Because pharmaceutical companies are not interested in getting fixed dose combinations, and also there's been aversion to fixed dose combination, particularly coming from the irrational combinations which are there with vitamins and others. But here, fixed dose combinations are very really useful in terms of improving adherence. Fourth, we always lag behind in terms of discovery to delivery. It takes almost 17 to 20 years, and we need to reduce that gap. Then, fifth is, it talks about technology, but the technology is a numbers game. For example, we have eSanjeevani, which is the telemedicine platform. That is basically the patient initiating a call and then talking to somebody, but it doesn't take the whole gamut of how to actually give virtual care, because it's a very specialized field now. That's not there. So there are lots of fragmented challenges. I mean, essentially what I'm saying is that the care is fragmented, and we need to think of in a holistic manner, as you said. And essentially it comes from our own medical training, I think, because we are taught in terms of reducing the body into organs to tissues to cells, and cells to whatever intracellular structure. But the thing is, science is like that. Science is reductionist. But when you have to manage patients, it has to be holistic. And especially if you have a national plan, it goes beyond that. It has to have a life course approach. And that's a missing element there. That how do you link maternal undernutrition, fetal well being, early childhood experiences to adult onset chronic diseases? And how do you keep people healthy? The whole paradigm of multiple long term conditions is not there. It's no longer true that you manage one disease at a time, because beyond 60 years, nearly 40% of the people have two or more conditions coexisting. What is the paradigm of care? We have not still defined. I mean, not necessarily in India, but internationally also we are not defined. So those are some of the things that we need to think of.
Yeah, thanks, Prabhakar. I think you brought out a lot of issues, a lot of gaps, both in the policy space and the implementation of the policy space, and also looking at only the public health delivery system as the whole system, ignoring the private healthcare, which accounts for almost 50-60% of it. Given this background, I will come to Himani. Actually, she's in place representing two states, to the governmental representatives, the Sachi's CEO, that is Uttar Pradesh State Health Agency implementing the PMJ, as well as the Principal Secretary Health from Kerala. Why I'm bringing this is on behalf of Access Health, she's leading the team which has been trying to address some of the issues both of you have raised. That how do we, with the existing policies, the design was that we have strengthened the primary health care through the health and wellness clinics or Arogya Mandis, and strengthening the other primary health care component, and provide the financial protection by purchasing from the private sector so that there is a hospital-based care as well. But one of the issue has been that the integration of NHM and NHA so that there is a continuity of care. So that was one of the challenge that was recognized as a part of our own technical support efforts, and also the government's intent to improve the health systems. The second element that was brought out in both the states and the governments also have brought out is the fragmented provider system, because the patient navigates across the private system as well as the public system between different providers according to their choice, convenience, and everything, right? But at the same time, there is no policy or attempt to achieve coordination between the different providers and navigating the patient across this provider system. So these are the two challenges actually are being addressed by the state ministries, some of them on a pilot basis to understand the challenges and coupled with implementation research also. This is based on some of the insights that are being gained through these type of dialogues, especially by listening to the patient voice, by listening to the community voice, plus the professionals' voices. So just by listening that and understanding that, so I will request Himani to just narrate what are the attempts being done. Yeah.
Can we have the presentation slides? Okay. So good evening, everyone. Like I said, I will not take too much of time, but as Dr. Reddy was mentioning, Access Health had this wonderful opportunity of being associated with 3 states of UP, Karnataka, and Kerala in last 4-5 years, where we have supported and got an opportunity to support the state in implementation of the Ayushman Bharat reforms. As Sir said, I think the policies, programs, implementations have been very well laid out. The challenge is in implementation, and that's where we have been supporting. So what I'm largely going to present is some of the interventions to what Dr. Reddy spoke about. It's not so much about NCDs, but it's essentially how do we assist and navigate patients and citizens through different types of care. So these are some attempts. These are interventions that were co-designed by the government. Of course, I'm representing, and I'm not going to present a lot of data, but essentially insights and how these were designed. Again, most of the audience is from India, so we know, but there are international audience. We are talking about a state which is as big as Brazil. We have 240 million people living in UP, predominantly living in rural settings. We do see over last several years, there is improvement in socioeconomic and demographic indicators. We see a big shift in the incidence of disease. Again, no statistics, but we know that there is rising incidence of NCDs. Also, the data that we see from PMJ and also state MIS shows higher number of patients that the state is dealing with. Again, in terms of the infrastructure, Ayushman Bharat reforms did attempt to bring that continuity and continuum. Unfortunately, it still remains very fragmented and very vertical driven approach. But in UP, there are close to about 23,000 health and wellness centers, which the states intend to set up. A lot of these are already in place. PMJ, I would think, did bring, again, a big boost to the availability of treatment, because it does provide a lot of treatment and management packages. It covers, of course, 500 million people nationally and almost 80 million people in UP. The third piece, which again, sir talked about and other speakers also spoke about, is that we are entering into a phase of digital use of digital infrastructure. And while the programs have to converge, I think the digital goods which have been developed as part of, again, the Ayushman Bharat Digital Mission are an important, will be important levers to really coordinate and make that care possible. Again, from a PMJ point of view, if you look at NCDs only, there are close to 1,900 packages, 25 specialties, which the insurance scheme covers. If you look at only in context of the most common NCDs, there are close to 700 packages, more than 700 packages, which are available for cardiology, CTBS, oncology, diabetes. But the biggest challenge, even when we look at the data from the treatment, is most of them come late. Especially for the oncology cases, they're very late representations, poor health outcomes. And of course, I'm not going to talk about those are issues which we know. Again, I'm not going to speak too much about the challenges, but it is fragmented because especially from a point of view of social health insurance, where first of all, it's not universal. Second, the care is fragmented. It's not available across hospitals. Patients, people don't know how to navigate. So there is definitely a lack of information on awareness, where to go, and most importantly, the continuity of care. So there are both demand side challenges and supply side challenges. I'm going to speak about 3 quick care coordination interventions that were designed to respond to some of these issues in UP. Now, the first was essentially through a PMJ helpline or a call center. Most states which implemented the health insurance scheme set up call centers, which was supposed to guide patients, ask queries, report grievances. And one of the biggest challenge which I shared was that most of the patients were landing in hospitals. Now, sometimes these hospitals were not empaneled. So they really didn't have the right information to reach the right place. So design with the government, we decided that we are going to plan 3 additional patient-centric services through the call center. And these were first offering hospital appointments. There were 2 kinds of hospital appointments. One, again, that focused on providing continuity, so more follow-up appointments so that the patients are coming back for follow-up treatments. The second was OPD appointments so that PMJ citizens know where to go. The second, I think, which the conference actually started with the engagement of taking feedback from the community. We started the whole practice of capturing what's called as PREM, so patient-reported experience measures, which looked at the satisfaction, the quality of services which the providers, and the money which patients were spending. And third was really, again, done on a limited scale, but whether the treatment was actually leading to any improvement in the quality of life of the patients who were treated. So these 3 services got introduced. They were tested on a limited scale in 2 districts, but results were good. Again, these are numbers. I don't want to, talk too much about the numbers, but essentially, especially from the exercise of taking patient feedback, a lot of both operational issues, the money being charged by the hospitals to the beneficiaries was recorded, actioned, and a lot of the feedback really pointed to good level of satisfaction from the scheme. So this was one, again, more of how do we provide more coordination services to people. The second, again, I'll not speak too much, but again, ABDM as a reform does provide a lot of opportunity, because over a period of time, we would have unique health IDs for all of us, which will help us maintain health records, have access to our health records. A lot of registries are being created. So this is not like a direct care coordination. It is more of a health systems approach of, it's a long way to see how we can encourage citizens, how can we encourage hospitals, both public and private, to start adopting digital health goods. So again, in few districts of UP, we are looking at digital saturation, where the attempt is that all hospitals, both public and private, move on to interoperable health information systems, which enable the movement of EHRs, which is again important to look at the continuity of care. We are encouraging the creation of ABHAs and linking the ABHA unique IDs with the EHR, which again provide longitudinal health records. And again, so this in small ecosystem, we are trying to bring the programs and encouraging more digital adoption. The learnings from these two care coordination, like I said, the programs, of course, have to converge, but we also have to find a pipeline which connects these programs, and the digital platforms in coming times is going to play an important role. Third, very quickly, I'm going to speak about cancer care because the session is on NCD. Again, cancer care remains, oncology remains the most utilized treatment in PMJ. And once we started looking at the data, we also realized that there were poor treatment continuity. We realized that the availability of treatment in entire state was very inequitable. We just have in UP about 500 hospitals for a state of 24 crore who are empaneled for oncology services. So we started with a lot of research. It was a multi-partner initiative with government, Roche, state health agencies who came together. And again, three kinds of recommendations. I'll not take too much of time, but largely, I think a lot of focus was on screening, systemic issues of notifying cancer in a state like UP, where the data is still very limited, establishing population and hospital-based registries. And more importantly, from a PMJ point of view, it was how do you, one, improve the health benefit package? How do you get diagnostics which still do not form part of health benefit package included in PMJ? Good couple of actions which the state took once they realized that the care is limited and people need care. They looked at actively going and targeting targeted new hospitals and empanel them for oncology services. Eventually, for the availability of drugs, the National Cancer Grid then encouraged the PMJ private hospitals to participate, and a lot of private hospitals participated in the pool purchasing, which actually brought down the cost of drugs and also improved quality. These were again some, I wouldn't say these also seem very fragmented, but these are some attempts to bring different program verticals, which again go very in a silo approach and really bring it together. For us right now as an organization, we are working on multiple projects of care coordination, for which both digital integration and convergence is extremely important to really maintain that bidirectional coordination. So I'll take a pause. This was more from an implementation and a programmatic point of view.
Yeah, thanks, Imani. I think these were some of the things that were being shared in terms of addressing some of the challenges in the systems. I mean, because some of these things may be outside of the policies. It is more of how you develop models of care that ensure continuity of care, and also that ensure all the health needs related to NCD, from health promotion to palliation. What you said, the life course approach. So these are the things that, this is an example of knowledge to action of the GLC, that whatever discussion that are happening here, I mean, as one of the health systems organization or some of the members of the GLC, they're actually listening to the voices, the community voices and the patient voices, and what are the gaps outside of the policy making, and attempting to achieve some solutions. And those solutions can be shared. Because two things you brought out in your point, Ram, is one, there is not enough health literacy related to NCD, which is one of the most critical things. So some of the members can take that up as one of their project and then showcase in the next conclave. There is a lot of work already happening. At least if people can come forward and start sharing that. What are the challenges of health literacy? Does it really change the behavior? If it does not change the behavior, then what we need to do? So these are the things then we can feed back into the government so that they can incorporate into their own because public health ultimately is the large system. Second is the rehab and palliation component of it, because from a policy perspective, with the limited funds being available, where the best returns are there. The best return, naturally, the health promotion, disease prevention, early diagnosis. But does not mean that there are millions of people who are already having the disease and they require disease management, rehabilitation, palliation. So these are the elements that we're trying to bring into the discussion here. I don't know whether Meenakshi Sharma is there, representing from the ICMR. The specific question I wanted to direct, because most of the countries in LMICs, we do not have our own risk tools. Like, for example, the risk of developing a cancer, the risk of developing a chronic kidney disease, or risk of developing a chronic lung disease or chronic cardiovascular disease. We still adopt the risk tools that are developed for the Caucasians and the Western population. The unique risk that we are facing, being a South Asian, we are double the risk of Caucasians. Being part of a crowded living, we are exposed to more infections, which again trigger more acute events in the non-communicable diseases. And also we are exposed to the poor air quality, which again is a risk factor. So if we have to adopt these risk elements into the risk measurement tools, that means we may be missing millions of people who need prevention, because the risk assessment may be totally different. So in this context, ICMR being the premier research organization, and I'm sure there have been attempts to evolve country-specific the risk assessment tools and the country-specific practice guidelines based on our context and our population thing. I would like to have your perspectives on this question.
Thank you. I thank the organizers for inviting me for this panel discussion. As far as the risk assessment tools are concerned, you have rightly pointed out that most of us are using what has been made in other countries rather than developing our own tools. At ICMR, we did go for some tools which are not really for hypertension and other things, but for mild cognitive impairment. We developed a tool, and I think we should be developing these tools more often. So that's one point which I have taken from you, that these are required, and we should look into how we can make the tools for our country. But having said so, if you look at what Ram said, so Ram said that on Sunday he was fine. On Monday morning, he was in the hospital with a heart attack. So something definitely is happening in the community. And one question which always comes to my mind is, are we failing our children? So, we are not able to keep them healthy. Is it like that? Or the tools which you are telling about, the risk assessment tools, we know that what is happening. We know that these youngsters are moving out early from the home, and they are now exposed to unhealthy lifestyles for a very long time before they get married and again get settled in a household environment. The food which they are having in the hostel canteens, the lifestyle which they are following, late night outings, sleeping late at night, not exercising. The entire blame I will not put on on these youngsters only. That is why I'm again and again saying, have we failed them? Have we not thought of organizing some of the things for them, making a better world for them? Risk assessment, we know that there are risks. The hypertension is there, diabetes is there, they're prone to, there is pollution over there. What do we do about that? That's much more important. So I was at Delhi University a few days back, and I was talking to the students,
And suddenly I realized that they did not even knew about the symptoms of a heart attack. So they did not even think what Ram said, that they don't think that they are prone to this condition. In hospital settings, we might be seeing people around 21, 28, 30, 33, 40, having stroke, having heart attacks, having some other chronic conditions. But in a university settings, the students are not aware of that. So as a policy, I think we require to have something in the curriculum. Some discussions should be held in the universities, in the colleges regarding these issues. Now, the private sector definitely, as Dr. Prabhakaran has pointed out, is most of the patients go to the private sector. 80% of our patients are going there. But the 20% who are going to the public sector, they are also not getting the proper facilities. So what at ICMR we tried to do was, we tried to come along with a hypertension control program, and we tried to build up the systems in around 150 districts. We registered around 56 lakh patients. And we were able to develop our own algorithms, some very simple algorithms, where we had only 3 drugs with us, and we were able to make the procurement of these drugs much more easier. But having said so, even then, that public health system will, in these districts, the control rate was around 47%. But if I look in the population, I think we made only a very small impact of 2 or 3%, because the private sector was not there. So that is something which we have to think, that how do we involve the private sector? We did try to do something in Ludhiana, where we try to build up a private sector model for control of a simple thing as hypertension is. So there also we tried to involve the industry, but then we found that we have to involve the ESI. And ESI initially was reluctant to be part of this, because they have a different, it doesn't come under the Ministry of Health. It comes under a different ministry. So to bring them on board was one of the tough things. Then we realized that this is something which we have to do, the railways, the ESI, the army corps, and they have to be on board when we are talking about the public health system too. We also learned in a hard way that because of hypertension, the Northeast population is bearing a brunt. 70% of the stroke in this population are hemorrhagic strokes, which is the highest anywhere perhaps in the world. When we look at other parts of the country, I think it's the opposite scenario. So here we have got 70% hemorrhagic strokes, and they are happening in the younger patients, 21, 28, 40 kind of thing. Every day the patients are coming over there, that in that age group. So the best thing there is going to be that if we are able to control hypertension in that population, then we will be able to decrease the risk. But definitely these risk assessment tools, which are specific for that population, have to be developed. That population, the pollution may not be important over there, but the issue of drugs, the issue of smoking, the other things have to be there. So I don't know whether we should have risk assessment tools for the entire country or for some specific populations. We may be requiring something which is different too. So there are many research issues which have been highlighted by the other speakers. And I think involvement of community is the most important thing. The other thing which I always feel is missing is the caregiver. So in the health system, nobody tells a caregiver what has to be done once they have a patient at home who had an MI or a stroke, how that patient has to be cared of. So he's left alone. As a result, I think a large number of our stroke patients die within 30 days of the acute event. Heart failure patients, same way, 50% they're dying dying in the first 2 or 3 years. So that's a large number which we have to tackle. Therefore, we will definitely require, as you have said, some risk assessment tools for our population. Thank you.
Thanks a lot. In addition to the risk assessment tools, I think there is also urgent need to have a basic sampling-based surveillance system for non-communicable diseases. Because otherwise, we don't know what's happening. Are we really able to make an impact on the growth curve? Are we able to really make impact on the prevention of premature deaths? So that is another requirement, I think, both from the Ministry of Health or the CDC, because these are not brought under the purview of the surveillance, but they also need surveillance like any infectious disease surveillance to know exactly are we able to control them. So that is another recommendation I think should be carried forward as a part of the research methodology as well. Thanks again, and I move on to the next panelist, Ratna Devi. She is not a patient, but she advocates for the patients and represents the patient voice and the patient perspectives, and also some of the policy suggestions and solutions. She was part of the committee for the National Action Plan for the cardiovascular disease, I suppose, or NCD in general, and also on in the committee for the WHO NCD space. So given this background, I mean, what are your perspectives in terms, because we know the challenges are there. We know that there are a lot of implementation challenges. Apart from the policy making, one is advocating for the policies, but apart from the policies, the other two arms of the governance, the private sector and the civil society, what they can do to address the challenges of NCD.
So the what you referred to as the CVD plan was very, very long back, and I am not even sure if it's in existence anymore. And as far as WHO is concerned, I'm on the NCD lab for lived experience. And this year is the 4th UN high-level meeting on non-communicable diseases, the first one being in 2011. And every year there are commitments made by member states on how to tackle NCDs. But however, in spite of 3 high-level meetings and lots of commitments, what has been seen and what has been discussed, and this was the topic of discussion entire last year at World Heart Federation meeting as well as the World Health Assembly in Geneva, is while there is a lot of discussion, there is no finance that backs the commitments. So there is language, but how do you implement that language? Where is the commitment? Where is the financing to be able to implement that language? And that financing mechanism, not only locally or country level, but globally, is also missing. So if you see how pandemics or other global health issues have been tackled, whether it is HIV or tuberculosis, there was a global funding mechanism for that, whether it is for research or for new molecules or implementation or even policy pathways or integrated care. However, with the non-communicable disease agenda, that kind of commitment is still lacking. And that is why this year's push is to find that financing mechanism which all countries that are member states to WHO agree to. However, because disease burdens, risk factors, and geographical variances are there, there is no unified voice, and that kind of commitment is still lacking. So while there are a lot of co-sponsors and signatories to these UN high-level meetings, there's no big country with that kind of power to finance, or start a global fund for, say, cardiovascular disease or NCDs that's coming forward to say, yes, we are willing to invest. And therefore, member states are left to their own means to find the funding and finance. So if we come back to India, though we have the Ayushman Bharat scheme for critical care and we have the National Health Mission for prevention, screening, etc., if you see the funding that is there for NCDs is just 3% of NHM. And that 3% is then distributed across 7 or 8 diseases, which are the focus areas. So diabetes, hypertension, COPD, COPD, not much screening happening at the community level. But cancers, we have 3 cancers, that mouth, cervical, as well as breast cancers. Some screening is happening at the community level. And then we have this big giant in the room called mental health, where we have a lot of initiatives that are being spoken about, but these are all vertical silos and not integrated into the NCD program. So if a person has stroke, does the person get counseling? If the person has cancer, does the person get counseling? And not counseling for acute care, but counseling through the continuum of care. That is not there. It's all very, fragmented, as was being said. So how do we, and Dr. Prabhakaran talked about multiple long-term conditions. So the general thought process is that, oncology program runs as its own vertical. The cardiovascular program or hypertension program runs as its own vertical, but many patients with cancers might have heart diseases and vice versa. What is also not being talked about, and there is a demographic shift of how our population is aging, is neurodegenerative disorders like Parkinsonism, dementia, Alzheimer's, epilepsy. I mean, you see populations that are suffering from this, but there is no focus on these groups. And we do know that people with, who are 60 plus, and even people, super seniors who are 80 plus, is increasing day by day. However, this has not received the attention that it should receive in the national NCD program. And therefore, while a 70-year-old with cancer might get treated, if that same 70-year-old has dementia, there is no treatment available, or Alzheimer's, there's no treatment available. And then, Madam referred to caregivers. Not only caregivers, with increasing age, a lot of these old people are staying either alone or as single couples. And therefore, they are not able to take care of each other. Whether they have a heart attack or stroke or any other long-term condition, they're not able to take care of each other. And we do not have institutional workforce beyond the ANMs and the Anganwadis who can actually take care of these old people and people with long-term conditions at home. We do not have that workforce of caregivers at home beyond the immediate family. And I think that kind of investment needs to be thought about as to how, with the shifting of the social fabric, where families are staying alone and you are having a decreasing age of onset of heart attacks and stroke, where just a couple might be there with children and the only earning member in the house has a stroke. How is the family going to take care of that condition, and who's going to take care of that person while the other spouse is busy trying to earn for the family and trying to take care of the educational needs and other needs of the children? So those kind of things have not been thought through, and that is why I think it is so important that we treat the human as a human and not as a sum total of the diseases that they suffer from. Because only when you look at it from that perspective will you look at a care continuum pathway and start to design programs that will prevent a second stroke or prevent a second heart attack, so that they are not pushed further into poverty. In terms of, again, a global voice, there is concerted action globally in terms of, say, World Heart Federation, the World Diabetes Federation, etc., coming together as a unified voice. However, we don't see that happening in our country for 2 reasons. One, there isn't enough voice. So there's only one Ram who is representing the CVD voice. We do not have anything in type 2 diabetes, which is a true patient voice. Stroke patients, there are a few groups available there, but they are not unified. And in terms of other conditions, and all these conditions coming together as one umbrella organization at the national level, talking to the Ministry of Health and bringing suggestions to improve or strengthen the policy or the program, is not happening. So that is something that needs to be invested in. And I think some of these learnings that you have through the Sachis program, etc., can actually bring a lot of value to patient organizations like RAMS, Heart Health India Foundation, and other foundations that are there working in the area of stroke, Alzheimer's, dementia, Parkinsonism, etc., and maybe bring together a national forum that can then feed into national policies and national programs.
Thanks, Ratna. I think for very important pointers. And tomorrow, I think there is a session dealing with the financing component of it, especially given the fact that the global funding is drying up, the international funding is drying up. So you have to look after yourself. So how each country has to look after yourself. There is an interesting session tomorrow, mostly focused on what are the innovative domestic financing, especially to address the issue of non-sustainable health financing arising out of non-communicable diseases. And the second element, of course, again, I think tomorrow 1 or 2 sessions may be there, looking at what is the appropriate models of care. So that's, I think, and the third element, I think 2 important, powerful points came out apart from health literacy, the cadre or the competencies that are required of a caregiver, either a professional caregiver or family member who is a caregiver, how they are trained and how they are built at competence. So these are, I think, important insights that can be built into these programs. Now I come to Parag, last but not the least, as a panelist. Your work on behalf of the JPIGO with reference to especially the cancer care. I think you have been involved in that. So some perspectives and some insights, because the GLC is throwing the insights from your own works. So that is the virtuous cycle of knowledge to action, action to knowledge.
Can I dare to use few slides? So first of all, thank you so much. And I said dare because I know you all are tired, so we'll keep it very brief. First of all, thank you so much. Thank you so much for this collaborative and Access Health for this opportunity. I'm representing JPIGO. It's a Johns Hopkins University affiliated organization working across multiple domains and thematic areas with government systems and professional associations. Before I start, I just, and like Dr. Krishna mentioned, I'm going to largely share about our cancer-related work. But before I go there, I really want to, break this silence amongst the audience. If you see this, what is this? 30, 60, 90. Any quick thoughts? Whatever remaining glucose is there, please use it and tell me. What is 30, 60, 90? No, that's true, but no, wonderful. Thank you. Thank you, ma'am. No, so, this is one number and one insight, one point that I really want you to take with you. Unfortunately, these are mortality numbers. 30,000 women die because of causes of maternal deaths in our country. It's a UNICEF estimate, it's around 28,000. 60,000, this is a Globocan 2022 estimate, 60,000 die because of cervical cancer related issues or cervical cancer itself. And 90,000 plus die because of breast cancer related illnesses or breast cancer itself. In fact, Globocan 2022 says it is 100,000 plus, 110,000 plus. So 30, 60, 90 is showing the magnitude of the burden that our women are facing. And we all know women and their families and all of that is related, right? Second number is this. Any guesses on this? 964. Again, not a very pleasant number. When cancer is diagnosed in US, this is a global forum, so I just want to mention some international numbers. When cancer is diagnosed in US, breast cancer specifically, because we all know that's one of the major killer of women, like we saw in the last slide. 9 out of 10 women get saved. 9 out of 10. So cancer, जैसे फिल्मों में दिखाते थे, या Bollywood has made cancer like a sad story. Everyone goes silent after cancer is diagnosed. It's no more so. There is treatment available if you diagnose and detect early, right? 9 out of 10 get saved in US, 6 out of 10 get saved in India or middle income countries, and 4 out of 10 only get saved in countries like Uganda or pockets like Uganda in our countries, right? So that sort of inequity is there in cancer care. And I think all the MNS panelists before me have already mentioned about different dimensions of it. If you look at, what are the efforts or attempts on screening or early detection, this is just single graph of the globe, which is talking about the screening coverage across different countries. There are many countries which are not at all there, But the good news is that today, and another sad situation I just want to put in front of you, because this is a forum where I believe we need to really voice out about it, right? So if you look at the inequities, first of all, numbers that are there in our registries, or do we really have the registries from the population level is a big question. But whatever we have, even in those numbers, the the magnitude or stage-wise distribution of cancer is not really there, right? I'm not going to get into the details of the graph. These are pretty self-explanatory graphs, but just want to again tell whatever we are detecting is actually already a late-stage detection, right? Now, but if we detect early, now this is regarding again breast cancer. If we detect early, if you detect even in India in stage 1 and stage 2, and unfortunately in India, it is coming 10 years earlier. The epidemiology says that younger women are getting affected because of different tissue composition, because of different genetic makeup. So our younger women are getting affected. The point that Dr. Krishna mentioned, and it was asked to ICMR madam, is around, are we doing something for Indian settings? It's a very valid one because it applies to cancer settings also. Because the mammography that is recommended through Western literature is not directly applicable to our settings, right? We might have to have different algorithms, and those are part of our national guidelines as well. But I just want to again say, early detection is so much important, because if we do it, more than 95% or 92% of women would get saved. And this is just one case that I'm putting in front of you as an example. Now, another good news on this front, and a lot of things are happening in cancer space over the last few years. These are the two global guidance documents or global strategies that have been released for countries to adopt. I'm so glad to have very senior policymakers in this room, because I think our current NP-NCD programming doesn't really touch these elements. So if this forum can, allow us to share some of these, I'm sure they already are considering it, but these two global strategies, one for breast cancer, one for cervical cancer, are out there. And there are efforts right now happening to demonstrate some of this on the ground. And as a Jopaigo representative, I'd like to share just two examples that we have done, and then I'll pause with my insight sharing. So at Jopaigo, we have been working on cancers for last, more than 3 decades, actually. Across different countries. Within India, we have started our aggressive programming in last 8 to 10 years. The approach that we follow is very simple. It's a 5-pillar approach. We start with awareness generation. Now, awareness is required not only for ASHA workers or frontline health workers. Awareness is required for managers, directors, and public health in charges as well. Because cancer, like I said, make everyone go silent, right? So we really have to demystify the cancer programming, and we try to do that. Second is screening. Now, again, screening is a technically, it should be a technically sound process, because if you don't have quality screening, no value of it. So we try to have, right capacity amongst our health workers on right screening modalities. Let's say if our national government says it's clinical breast examination, absolutely yes. We help health workers to do correct clinical breast examination. If it is VIA, we try to teach them around that. And all my colleagues from Access Health know the ground situation. So the importance of this knowledge to skill to practice is something that I think is a real investment. The third is diagnostics, right? And here, again, there are major learnings. Because see, what is happening in NP-NCD, there are 5 diseases, let's say, right? And there are many that madam spoke, but diabetes, hypertension, and 3 cancers, if we at least take the top 5. Now, if I am a CHO, I know what to do if patient is diabetic. At least immediate next step is known to me. If hypertension, I know what to do. For cancers, I absolutely have no idea. If there is a lump in breast for a client who is visiting my center, I don't know what to do, where to send. The only answer is regional cancer center or a medical college or a district hospital, right? But that linkage sort of a thing that we try to do in areas where we work. And finally, for management piece, we reach out to our collaborators, partners, and entities who are actually supporting and working at that level. All along, naturally, recording and reporting is a 5th pillar where we try to invest. And based on that, I'm going to show a few numbers with you. Now, like I was showing, and madam spoke about the continuum of care. I think this is the simplest continuum of care that we follow. We try to, establish this continuum of care in areas where we work. And really invest into defining those resource stratified workflows, right? And this is a published paper. I'll share link also if required. I'll just give you one real example before I close. What happened incidentally in Uttar Pradesh itself, we got to work with around 100,000 population in collaboration with government. and health workers were given the necessary tools and capacity to actually mobilize all these clients to health and wellness center. Even when that happened, only 68,000 actually came to the health center for n number of social reasons. And if you see all along the continuum, finally we got to find only around 27 patients who actually had some malignant issue. And there is a lot of dropout. Now, that is the first part of this slide is actually our failure, I would say. But I'm very proud to share that because this is an insight sharing session, right? So there are so many barriers that we saw right along that continuum. We are calling the patient to the diagnostic center. There are a number of reasons they are not coming. Even if they are coming, all 3 tests are not happening in single setting. So how do we really make it happen? How do we ensure that this continuum is strengthened, right? But even for these patients or even along this continuum, the success story is right there at the bottom. The diagnostic delays, the time to complete the diagnostics actually reduced from 22 days to 2 days. The diagnosis of these 21 clients that were identified was actually in early stages, only stage 1 and stage 2. I don't know if they would have got delayed if they were not part of the program. And the third thing, and this is in comparison with the tertiary institution at Lucknow, the size of the tumor. Because if you have a breast tumor, the staging is dependent on the size. The 4.5 centimeter, which was reported at the tertiary institution, we found the average size of the lump was around 3 centimeter. So there is a down staging, there is a downsizing, and thereby showing some impact. Now imagine the impact if all these clients would have followed the continuum. But like my colleagues have mentioned here, there are so many bottlenecks and so many interventions that we all have to collectively do to ensure that everyone who is getting into the continuum is actually completes the care continuum. This was an example of a breast cancer related work. Something similar is right now happening to see if cervical cancer related interventions or strategies can be contextualized for Indian setting. Right now we are working in Sikkim and Uttar Pradesh for it and Odisha. But I'll not get into those details. Very happy to share additional insights as required. But then what's next for us, right? So if you are really thinking of building these resilient, health systems, I know odd situations will come, but even today, if you really want to address this silent pandemic, I'm just going to summarize probably the words that my co-panelists have used. We have to have integrated efforts. We have to really do aggressive health promotion for early detection. We really have to emphasize on self-care because incidentally, there are today self-breast examination. There is a self-sample collection for HPV DNA testing for cervical cancers. Those modalities are available and the models are being demonstrated for it. There has to be a decentralization of diagnostics. If I don't have mammography, I can do it through ultrasonography, but we have to build capacity for it. Smart solutions are required. Smart, when I say it's tech-driven, tech-enabled, I think that was spoken. Care navigation, and finally, the context-relevant workflows is something that we all have to probably really invest into. So I'll pause there, but thank you so much for this opportunity.
Thanks, Parag. I think it was a wonderful summary of the whole discussion points. I just want to quick summary of the whole discussion and also the action points going forward. I think all of us are convinced that the government alone cannot do this. I think that's the first summary of this. Second is, unless all of us, in fact, in the morning session, why we invited philanthropists and industry and other people is, if everybody join hands in terms of whether it's a financing aspect of it, whether it's a models of care, whether it's a research to guide the policies, if everybody collaborates and everybody contributes and everybody freely shares some of these insights, we can, I think, overcome this challenge of NCD, including the surveillance. If the government does not do surveillance, let us do surveillance. Why not? It only requires our extra time and extra brain. So with this, I think the closing words, we are end of today's exhausting times. But at the same time, I think we can relax and network now and then. I'm not sure if anything is there to relax us. Not allowed. Okay. Over to you, Uma.